we have analyzed this data in both non-ICU and ICU settings, and when you see the glycemic control of patients, even after you give them a window to get to goal, for example, the first 24 hours, we know that in a few hours, if you start the patient on continuous insulin infusion, you know that you can achieve target right away. So 8 hours, 10 hours, the patient should be on target. But if you're not treating them with continuous insulin infusion, you're very unlikely to achieve those goals. And you can see, for example, here on the right side of the figure, that those subjects with oh yeah, absolutely. Let me cut this down. Yeah. So so if you see this folks here on the right side, after 2 days of being in the ICU setting, if you didn't achieve goals, if you're still persistently hyperglycemic, you can see that those patients have the lowest survival probability. And in the hospital, we've treated patients with several different regimens. We've used insulin formulations, non-insulin formulations, and in general, when we treat patients with a basal bolus regimen, which is one of the most common regimens, we can achieve glycemic goals in most patients. And the rate of hypoglycemia, maybe with the newer insulin formulations, maybe with simplified regimens, is a little bit easier. But there's still a population of patients that cannot achieve goal despite being on basal bolus, particularly those that come with higher glucose levels. We've shown this also with combinations of oral agents with basal insulin. This is a study comparing basal plus a DPP-4 inhibitor compared to basal bolus therapy. And you can see that the response to therapy is pretty similar. So you can consider simplified regimens for patients, and it worked in a large proportion of them. However, when we look at those patients that have the highest glucose levels, it tends to be harder to control them. So that's why we recommend using basal bolus for those people. But for those with mild hyperglycemia, if you come in with a glucose of 150 and your A1C is low at home, you're just taking maybe one oral medication at home, it's very easy to treat those patients. If their glucose on admission is 150s, 180s, in general, with very little, we can achieve goal in those patients. So we can usually treat them with an oral agent or basal insulin alone. However, for those patients with higher glucose levels, it gets a little bit more complicated. And in the ICU setting, in general, the recommendation is to treat patients to keep them in a target of 100 to 180. For medical patients in general, 140 to 180. For surgical patients, maybe lower targets are better. But to reach those very narrow ranges, it's really hard to do it with sub-Q insulin, and we typically fail. So that's why we recommend using continuous insulin infusion. The same for those patients with severe DKA. And during the pandemic, we started using a little bit of subcutaneous insulin protocol, because if the patient has not have severe DKA, there's some studies that have shown that insulin injections every 2 to 3 hours can work and help control those patients. So a limitant during the pandemic, obviously, was the need for monitor these patients frequently. So a major challenge in the ICU is the need to do a point of care test every hour to be able to adjust your insulin infusion. So you cannot just leave the insulin infusion and walk away. You have to monitor those patients every hour to make those insulin infusion adjustments. And on the floor, if you have a patient on basal bolus, you in general need to test, since they're getting multiple daily injections, you need to test at least 4 point of cares 4 times a day in most patients. And this was obviously not possible during COVID. You remember there were no masks, no gloves, no sanitizers, no personal protective equipment, people improvising using trash bags. You remember at the beginning, it was really a disaster, and nurses dying. It was really, really, really bad. So the technology that was available when the pandemic came was really allowing us to modify the ways we treat people in the hospital, and that obviously has been changed in both the inpatient and outpatient setting. This slide is just showing some of the evolution on the technologies from from the first insulin more than 100 years ago to the different ways that we can deliver insulin. Examples of the insulin pumps that have been available for a long time. And similarly, the way we monitor glucose from urine samples to the first glucometers in the 70s to now continuous glucose monitors. And at the same time, there's been a huge advancement in telecommunications. You know, everybody has a smartphone, and that has really reached the whole population. Most even patients with disadvantaged conditions, low socioeconomic status, they more than 80-90% of them already have a smartphone. And obviously the advances in communications and the use of the cloud and the way we share data. So when the pandemic came, we have these 4 systems available for continuous glucose monitoring. From left to right is the Libre, then the G6 from Dexcom, the Eversense, and Medtronic. And the 2 on the left side do not need calibrations, meaning that you don't need to check a point of care and enter the glucose value into the system to make sure that the sensor is accurate. They come as factory calibrated. And those were the devices that were being shipped to hospitals to monitor glucose levels in patients, to try to do it remotely, to not have to do that patient contact every hour in the ICU or every 4-6 hours in the non-ICU setting. So in April of 2020, the FDA did not object to the use of the sensors, and Abbott partnered with ADA and delivered sensors to hospitals. The same Dexcom created this inpatient hospital group that was helping hospitals implement the technology. So, but this was not totally new for the inpatient setting. Before the pandemic, already years earlier, there has been a lot of interest in testing these technologies, a lot of observational studies, pilot clinical trials that were ongoing when we started implementing that in the ICU. So now we've gained a lot of experience. There's a lot of real world data coming out. There's not huge clinical trials looking at clinical outcomes, but there's studies that have been looking at glycemic control outcomes, which are kind of intermediate metrics. And there's breakthrough designation for the analysis of the G6 in the hospital. So it's accelerating the process and how this is going to be evaluated by FDA for approval. There's still guidelines are not accepting this as necessarily the technology that is going to replace the way we do things, but at least as an adjunctive therapy, we're using in some settings. We had already some preliminary data in terms of accuracy for the G6 in a large study enrolling several patients with type 1, type 2 diabetes. You can see here that the pairings of CGM values and point of care, and you can see that the correlation is pretty good. Most of the values are in the zones A and B, meaning that those are the zones where the technology that we're using is reliable. We're not going to commit too many errors when we're treating our patients. And if you look on the right side of the figure, that's the ARD, the absolute relative difference between the CGM and the point of care for different categories of glomerular filtration. So, meaning that on the right side, as you can see here, the patients with renal failure had also good accuracy with the sensors in the non-ICU setting. So this technology is reliable. The initial pilot studies suggested that if we enroll patients with significant risk of hypoglycemia, on the left side of the slide is data from the group of Ilias Espanakis in Maryland. They randomized patients with high risk of hypoglycemia to real-time CGM versus point of care, and with a tablet at the nursing station, alerting the nurses for a risk of hypoglycemia, they were able to intervene on those patients and prevent those episodes. And they showed a reduction in the number of events per patient. You can see for both less than 70 and less than 54. Another clinical trial that was analyzed before completion is a study by Adi Foreman from Scripps. They randomized patients to real-time CGM versus usual care, and they have also this telemetry system. And when they use real-time CGM, the mean glucose achieved was 191 versus 212. The goal is less than 180. So we don't know how significant this is in terms of the clinical importance of this finding, but at least what we can see in the lower part of this figure is that at least we're reducing the time spent in severe hyperglycemia when we use CGM. The time in range for 70 to 180 was not different between groups. Unfortunately, these patients didn't have well control. Most of them spending like only 20% of the time within range, 70 to 180. So there's still a lot to do, and you can think that there's a lot of patients that we can actually not achieve goal in the hospital. So based on this initial findings, we got together with some colleagues that had experience using the technology in the hospital, and we start thinking about how can we implement two systems in the inpatient setting. We came up with some recommendations or about who are the potential candidates, and also provide an easy access to what are the typical things that we need to think when we're using these devices. How long does it take for those devices to start working? What are the ranges they can read, the duration, the potential interferences, interactions, potential limitations in the patient populations. And I'm going to show you a little bit of what we've done at Grady Hospital and with other colleagues. This is the model that we've been kind of using. So basically, these devices need to be about 6 meters or 20 feet from the smartphone where you can get the data. So if you place the sensor on a patient, you can be outside of the room and you can get the data on a receiver or a smartphone. And if you're using a smartphone, that data can go to the cloud, and you can send that data to followers. Someone in the endocrine team can be following the patient in real time. The data is obviously transferred to the platforms that these devices have for summarized data, like the AGP, for example, the ambulatory glucose profile that gives you an overall picture of glycemic control. And there's a lot of interest on integrating that CGM and those CGM reports in the EHR. And I know you guys in Florida have been implemented this to care for patients. And one important step in the hospital to us was the using a method of validation of those glucose values to make sure that we were comfortable with using CGM, because we didn't know about interferences, potential limitations in the hospital. So the use of a protocol for making sure that the system was reliable was very important to us. So in the ICU, obviously, we were talking about hourly point of care testing is really not feasible, especially during COVID. And a lot of centers started changing their protocols and using subcutaneous insulin to treat the sickest patients. And that's really not optimal, and it's really hard to control. So we started looking at our own data. This is data from CABG patients, patients with coronary disease undergoing cardiac surgery. And we started looking at the data in patients that were receiving IV intravenous vasopressors. So we started seeing some initial limitations on the use of this technology. On the left side are people that were using sensors that performed well. You can see on the left side of the figure, here's our first one of our patients. You can see that the line in blue, we have those intermittent gaps in signal. Those gaps happen frequently in the OR. So it seems to be related to the electrocautery when the surgery starts. But if those devices got back to reading within range, those devices did very well when patients went to the ICU and they were on vasopressors, patients with shock. All those patients were receiving norepinephrine or vasopressing. You can see that those devices work pretty well. However, when some of those sensors had longer gaps, they didn't recover after surgery. Those sensors were not reliable after the patients were transferred. So there's some initial issues that we started noticing. We analyzed data with Shivani Agarwal from Einstein. She treated some of the initial patients with COVID, and the data showed good reliability of the G6, which is the real-time CGM that they were using at that time, with an MARD of 12.5, similarly to what we saw in the non-ICU setting. Then, based on that data, we got together and started with several stakeholders in our hospital, thinking about how can we integrate this technology to care for patients that needed the most the use of continuous insulin infusion, because patients were not being treated with the standard of care. So we designed a protocol to integrate the G6 with a protocol using point of care testing with a glucomander, which is an algorithm for continuous insulin infusion, and we added EHR documentation. So we got everyone at the table during several Zoom meetings to create a protocol. People from the endo team, nursing leadership, nurse educators, pharmacy directors, lab team, bioengineering, ICU team, safety officers, unit managers, administration, et cetera, to create a protocol to implement this in the hospital, not for research, actually to care for patients with COVID-19. So we used a smartphone outside of the patient's room with a protocol for exteriorizing the insulin pumps, glucose telemetry with a tablet in the nursing station, EHR documentation with a validation protocol. We use glucomander for continuous insulin infusion, and remote monitoring by the endocrinology team, PharmDs. And obviously, you can also follow up data of multiple patients with the dashboards available. So this is an example of our patients treated. The phone outside of the ICU, the externalized pump, the monitoring remotely in the nursing station, and a protocol. So essentially, what we did is create a system where nurses can document the point of care testing, and they will get automatically the range. For example, this point of care test for this patient was 136. The CGM value at that time was 134. The nurses get the range. The range is 108 to 160. So this sensor is working well, is within that 20%, is validating. So the nurses can use the technology to adjust insulin values every hour. So instead of using point of care, the nurses started using CGM as long as the CGM sensors were reading within that range. And when we looked at the initial values from our first 9 patients with COVID in the ICU, we saw that all the sensors, actually the first reading was pretty accurate, but pretty reliable. So you could start using the system right away. So you place the sensor, it takes about 2 hours to get your first reading. You can see here the correlation between the first CGM value and the first and the POC at that time, and that only one patient was outside of the 2020 range of patient number 4 here, where the POC was 127 versus 174. So in those cases, you will just calibrate the sensor and reassess. This is an example of our initial patients treated with the system. You can see a high variability. These are old patients, intubated, on vasopressors, really sick, many of them on CRRT, on parental nutrition or tube feeds, hard to control. But you can see that the patients, once they started the system, in general tended to have relatively good control. The time in range was around 70%. You can see a lot of variability on some of those patients. But for example, on our first patients, we really got a lot of problems with the technology. There was a first initial cardiac arrest. You see that the sensor starts reading low when there's hypoperfusion. You can see that there's a sudden drop in the glucose values. Then the patient had a hypothermia device after he was resuscitated on top of the CGM. So you can see again that there were some interferences here. You can see interference in the sensor readings. Then patients were rotated for pronation, either for the protocol or when they were getting a bath. They will be pressing on the sensors, and then we started getting this confusion: is the patient having a cardiac arrest? What's going on? So we will get those alarms in real time, contact the nurses, and see what's going on. So there's still limitations that we have in the ICU, but if you have a protocol to to address those issues, you can easily identify them. So we've pulled recently data from 3 centers. This is with Kathleen Dung and Eileen Folds from Ohio State University. They were some of the ones that started using first CGM in the ICU, and along with Miller from Stony Brook. And we have more than 150 patients with COVID-19 treated in the ICU, really sick patients. And we wanted to learn and see if there was interferences or issues in accuracy in the sickest patients. So we looked at the lowest pH, the lowest O2 SAT, the lowest PaO2, the lowest MAP, and you can see that there does not appear to be a correlation with those extremes in hemodynamic values, suggesting that the technology remains accurate. So what are other directions in the use of technology in the hospital? Is AID an option, automated insulin delivery, or closed loop systems, or the artificial pancreas? So there's several systems in the US. There's 3. We have Medtronic, Omnipod, and Tandem. In Europe, there's also the CAM APS from the University of Cambridge, and also Diabeloop in France. So the only data that we had available comes from the use of the CAM APS system, initially used with a different insulin pump, but the data has been published in the England Journal and other papers showing that the use of AID can significantly improve control. The problem with the approach that they have used is the use of expensive insulin pumps with tubing, that makes it a little bit complicated for implementation in the hospital, but the technology works. So we still have a gap in care in the hospital, which is essentially those patients that have more difficult to control diabetes. We have no studies with type 1 diabetes in the hospital, so there's really very limited data. We know that the technology can help us reduce the amount of point of care testing, but there's also a need to understand how to best treat patients with type 1, patients with steroid-induced diabetes. There's no good protocols. Those patients with medical nutritional therapy, they're really hard to treat. So there clearly is a need for use of this technology. Apologies, the slide is not very clear, but this is just data from using the Omnipod system in type 2 diabetes. So there's now increased interest in expanding the use of automated insulin delivery to other populations. So those patients that need intensification of therapy that are already on oral agents, GLP-1, insulin, adding AID can actually improve glycemic control. So there's reduction in A1C, improved time in range. This is just pilot data presented at ADA recently. So we got together with Stanford, University of Virginia, and JABE as the data coordinating center. We put together a feasibility protocol. It's called the Automated Insulin Delivery for Inpatients with Dysglycemia or AIDing study. So this is the feasibility study. We just recently completed enrollment. This is an example of what has been used at the University of Cambridge. You can see the insulin pump here hanging for the patient with the tubing and the devices, and what we have used with AIDing is the Omnipod system, simplifying this with a small disposable patch pump that doesn't require tubing. There's less risk for contamination if you're using the pump in other patients, and you have a single smartphone that can carry 2 mobile apps that allows you to deliver insulin remotely. You can actually have the phone outside of the patient's room and deliver insulin for patients, and this was with the idea of implementing this for COVID-19. So you can deliver insulin remotely, you can monitor insulin remotely, you can also do that not just outside of the room, but actually anywhere in real time, and you can access the insulin delivery also remotely. So for this study, we placed the devices on patients with a phone in a locked box. The data goes to the cloud and it can be transferred to the nursing station. So we have remote real-time CGM for the nurses and then remote monitoring for the study team. We implemented the protocol we had for the ICU now is implemented at the 3 centers. All centers are documenting CGM values, and nurses have access to the 2020 range that allows them to document if the sensors are validating at that time. There's an example here, the sensor is validated, but sometimes the sensors are not accurate, and you need to either calibrate or change those sensors. You need protocols for that. And this is just an example of one of the patients treated with the Omnipod 5 system. This is a 48-year-old African-American patient with type 1 diabetes. And you can see before AID in yellow on the left side during MDI, you can see it's really hard to control with high glycemic variability, extremes of glucoses, more than 500 or repeated episodes of hypoglycemia. When we started AID, significant improvement in glycemic control with a quite significant reduction in the variability, as you can see. And then when the patient completed the study, went back into MDI, monitored by endocrinologists with frequent adjustment of insulin doses. And you can see again how hard it can be in some patients to control their glucose levels. And then here again, very severe hyperglycemia, recurrence of hypoglycemia, making it really hard. So when we look at recently published studies with real-time CGM in the hospital, here's a brief summary of some of the recent studies that have used the G6, for example, the first 3 on the left. You can see that in terms of glycemic control, we're still not achieving goals. So for example, the study by Fordman that I showed you, 192 versus 212. So we're still not reaching control in several patients. In a recent study we published in Diabetes Care, 183 versus 189 on average, comparing real-time CGM versus point of care. No difference in time in range. Also no difference in the incidence of hypoglycemia. In sub-analysis, a postdoc non-pre-specified analysis, there was a reduction in recurrence of hypoglycemia. So if we had one episode of hypoglycemia, those patients were at risk, had a lower incidence of recurrent episodes. But one of the studies, if you can see here in COVID-19, this was in Europe, people on real-time CGM actually tended to do worse with lower time in range, higher glucose average, not significant, but still showing you that if you don't implement the protocol to use the technology, you will not be able to improve your patient's glycemic control. We've looked at 2 different intensive regimens with glargine, with 2 different kinds of insulins, also unable to reach target, despite daily adjustments of basal bolus insulin and the time in range using a different technology with the Libre Pro tended to be also similar. And when we looked at our recent data, it's going to be presented at ATTD. The time in range achieved with AID in this pilot study was about 68%. With minimal hypoglycemia. This is a single-arm, multi-center study, so this is preliminary data that we're using for a large clinical trial proposal. And how does that compare to other AID studies? So if you look at the previous data by Leah Bali from Switzerland in collaboration with University of Cambridge, you can see that what you can achieve with AID is pretty similar to what we saw, which is a time in range of about 65%, 60-65% with that technology. They used 100 to 180 as a cutoff. So this data will be presented at AID. And another technology that we are testing in the hospital is a system that is designed for the ICU setting. It's called the Fusion system by Ideal Medical Technologies. We got a recent SBIR grant where we will be testing the system in the ICU. But essentially, this is data, preliminary data from our first in human studies. In this figure, we're showing here that the average glucose in these patients, or the time in range, as you'll say, you can see that the glucose control in these patients is really, really good and on target. You can see that the lines, the light blue lines are the range, 70 to 180. So this patient spent 100% of the time in range. The second patient also, just at the beginning, before starting therapy, and these are patients with type 2 diabetes, with high A1C, on multiple dose injections, we put them on the system. And how the system works is two CGM devices that are feeding this algorithm. And this is an artificial intelligence-based algorithm that is infusing insulin and glucose at the same time. So using a closed loop system in the hospital with this technology can potentially help our patients have much better control. And one of the gaps in care is that we learned initially several years ago from data from Vandenberg in Belgium that if you can keep the glucose levels in a very tight control and maybe even aiming for euglycemia with a target of maybe 80 to 110, you can reduce mortality versus usual care. A large study called the NICE sugar trial was not able to reproduce that data, but there was a lot of hypoglycemia when people tried to do intensive glucose control in those people. So this is one of the potential approaches that can help our patients reach a really tight glycemic control without an increased risk of hypoglycemia. There was virtually zero hypoglycemia with this approach. So we're expanding the study. We're doing additional patients before we move to the ICU. So this is a table just summarizing how the diabetes ecosystem is expanding. You have all these companies listed on top with their devices, and they're all creating this digital health solution, these digital health apps that allow us to monitor the data, to share the data, and then to summarize all that data. So you have apps that are for the patients, apps for followers, and then you have the platforms for integrating that data and summarizing that data so that you can interpret the data over time. There's, as you know, several platforms that allow us to collect data from different devices and standardize the report. So there's still a lot of work that needs to be done to have a single standardized system, because many times we're struggling with data comes from one device. We need to go to different platforms to get the summary data. So there's still a lot of work that needs to be done there. But remote monitoring in virtual care is a reality. It's just about the implementation that we need to work on and how to best use this to improve the care of our patients. So in conclusion, we have shown that real-time CGM appears to be accurate in both the non-ICU and the ICU setting. There's now studies using YSI as the gold standard for glucose measurements compared to the G6. And these studies are still ongoing to see if there's any interferences in hospitalized patients. There's multi-center studies. It also appears to be safe based on the real world experience data that we're getting, an initial small randomized control data. There's additional studies ongoing. There's now a multi-center trial coordinated by the J Center for Health Research. We're part of it. We're enrolling patients and randomizing them to real-time CGM and targeting lower glucose levels versus higher glucose levels with the use of this technology. In addition, we're doing a multi-center study with G6 as well to assess for interferences in the ICU setting, hundreds of patients, to see if there's anything else that is affecting the readings of those sensors. Sometimes we don't know what's going on with the sensors. The sensors are just reading higher, maybe 50, 100%, 100% points higher, and we still need to learn about potential interferences. And finally, just to mention that the use of AID is a potential option in the hospital. Our preliminary data suggests that we can achieve much better control in our patients. We still need to conduct the larger clinical trial, and this may be feasible for both the non-ICU and the ICU setting. So I'll finish with that, and I'll be happy to take any questions. Thank you.
Kind of at that stage, right where you were, when you pulled together all the nursing to try to implement CGM. Do you have any sort of ones for things like well? Do you have any tips or hints of how we can move the process over to help implement that?
Yeah, absolutely. I think one of the of all the steps, what the most critical one to me is identifying the nurse champions that can take a little bit of ownership of the process, and this is not just helpful for patients but also for nurses, and see if they can see that benefit and say like, hey, okay, I want to learn how to do it, I want to learn how to place it, how to change it, because that's the problem, is that the disconnect with the physicians that may not be able to change it or place it when it's needed. So identifying those people that are going to advocate for the use of the technology, once they use it, the satisfaction is almost universal. So identifying them, then obviously hospital leadership, which are the ones that are going to say, yes, you can use the technology in the hospital, and then connecting everyone. I think it's sitting at the table whoever you think needs to give you the okay. So we had to invite the lab because they thought that they will be involved, even though there's nothing that goes through their system, but we just had to get their okay to say that we're going to document CGM values in the chart. We had bioengineering also at the table, because these are devices using in the hospital, see if they have any restrictions or any questions about it. And then I think it's right now it's more an endocrinology with nursing communication, because I think it's really tough to try to teach primary care providers, or unless you have hospitalists that are interested in using the technology. So getting as much people as you think is needed at the table to have those initial conversations, and then having the conversation with your IT people is helpful, because everybody wants to see what's going on. How can I see the data? Because if you just place the device, nobody can see it remotely. We don't know what's going on, but at least documenting in the chart, finding a way to integrate a slot for CGM documentation, I think that is also helpful and gives a peace of mind to everyone. Yeah, that's the exact question that Mike had earlier today. And we did it only for COVID. So now it's implemented for COVID, and we are using it kind of on the side for type 1. So patients with type 1. But the way it was set up, it was the ICU takes care of it. So the nurses are the ones who can call administration to order more devices. So there's not yet a process that goes the billing directly to the patient. It's more like the unit is buying, or the hospital is buying the devices. So they go to the ICU, and then from then they coordinate, they keep track of what those devices are. So the conversation we're having right now is with pharmacy, to have them on formulary and to try to create a path so where endocrinology can order the devices. And then it's still going to be a little bit of a curve to train different units and train nurses on how to use this technology, but those are kind of like the first steps we're thinking. Yeah. Type 1 diabetes patients that higher to the low implemented the system and think that know all about when they're adults. We have that exact same pattern, and I think that just that alone and having a system product that would be enough to solve the problem. Yeah. No, absolutely. It's a day and night. You can see, I think with CGM, we can improve maybe a little bit and reduce the severe hypoglycemia. We've used it in pregnant patients with type 1. And we can detect it, call the nurse, hey, the patient is going low. So that helps. But improving glycemic control is like the tougher part. And I think AID has a lot of room there for improvement. Oh, let's take a look. Yeah. The question says, how long can the AID system be maintained for the inpatient stay? So with the current technology with Omnipod that we've been using to test it, You have to change the pump every 3 days, and the CGM lasts for 10 days. So if a patient has a shorter length of stay, maybe you just need one CGM device, but you will need to change the pods every 2 to 3 days. There's something particular about the Omnipod system is that it takes a little bit to adapt until you change to the second pod. So the first one, it is a little bit more conservative, but once it has learned about the patterns on the patient, once you change to the second pod, it tends to be a little bit more aggressive. And I think that's in okay. Some of our investigators want something that adapts quickly, that gets the patient control. So those are some of the conversations we're having right now. But this is still experimental. I think the key part of this is that the nurses are trained to use the devices. So we place it, but the nurse learns how to bolus. Now it's really convenient that the trays that patients get with their meals, they have an actual carb count. So you can see the carb count, you know, and you ask the patient, what are you going to eat? And you say, like, I'm just going to eat this and this and this. So the nurses, what they do is they enter the carbs that the patient is going to eat for that meal. And I'm not going to eat any carbs, and then they just do the correction if needed. So that's been also very helpful. Back. In what sense? About the engineering part. I don't know exactly. There's a lot of literature. I don't know if it goes directly, but there's a couple of journals that probably have more into the details of that. So maybe the Diabetes Technology and Therapeutic Journal, or the Journal of Diabetes Science and Technology. You may go to the initial, but I think it's a lot of proprietary information. They may not want to give you how the actual algorithm works, what they have, but there's some literature out there. And also going into the package inserts, you can have a little bit more details on the data. And FDA, sometimes you can get access to the approval process. You can get information about how they got to the approval. Good.
So I struggle with how we work this into our clinical care operation. How do you balance the RT-CGM and patient care and humans under the healthcare system and a nurse or even folks in that? How are you going to balance those things? MR, having information, the right amount for much.
Right.
Where does the guy kind of play?
Yeah, I think we're very early stages to address those issues. You know, there's so much data, and is that safe? Are we going to take action for data that is inaccurate, or how do we interpret all the information that we are getting from these devices? I think the most simplified way that we can use it, I think the outcome to me is glycemic control. The outcome is glucose. So I don't really care too much about how much the AID system worked, when it was on and off, or how much insulin it was adjusting or not. If I can see the outcome, which is glycemic control, the patient is safe. So I think the most critical parts right now, since that we don't know about interferences and issues, is having the minimum is to have a protocol to reassure the team that what you're using is safe, and then some sort of way of implementation, some path to not overwhelm nurses in how much they need to do for the use of this technology. So having maybe a couple, 2, 3 nurses at the beginning that know how to use the technology, place the devices, and they can help others, then I think that it's a good start to getting into the system, and sometimes the in-service trainings. In terms of the use of the data, it becomes challenging because the clinical trials show that implementing real-time CGM does not improve that much glycemic control. So we still are in the initial stages of learning how to best use the technology. So I think definitely there will be a room for using advanced technologies, AI, to interpret the data and come up with those recommendations, particularly in the non-ICU setting, where we struggle the most. Because if you have the data, what we're using right now with CGM, you place the sensor, you look at the data, but you adjust the next day. It's not like AID that is adjusting every 5 minutes based on the glucose value. So we're still behind in how we're using the technology. So people in Europe have are using some sort of algorithms to try to advise nurses in every point of care on how to adjust the insulin based on that value. So I think that's the gap right now, is on how to optimize the use of that technology. So I think AI will be great for having some sort of algorithm that helps with that. So in the hospital, I think we are a Grady hospital, so we're treating the most disadvantaged patients, low income. So I think we can at least optimize it in the hospital settings. There's now the sad part of maybe using this technology and then the patient wants to use it. The patients that use the Omnipod 5, they universally liked it and they want to go home with it. So obviously there is going to be issues and disparities there in terms of who can go with the device home and continue to use these devices. So there's obviously a lot of discussion that needs to continue into making sure Medicaid, Medicare start reducing those restrictions for the use of technology and people that really need it. And sometimes the insurances are really hard to navigate, because you need to go through all these processes through DME, the device medical companies that it makes it really hard sometimes for patients to get the technology. So learning how to navigate those better. I think that the protocol that Brittany just got funded here, Brueggemann, I think it's going to be interesting in the sense of trying to learn what is the easiest way to help providers prescribe more of this technology and actually get the technology for their patients. So her pilot project is on interviewing providers, IT systems, on how to create a dashboard to facilitate the prescription of those devices to underserved patients. Because the typical thing that we've seen, and Ashby has published on this, your group, and on how much disparities there is and how endocrinologists don't even offer this technology to patients. And it's probably because of all the barriers that there are, or the assumptions that the patients will not know how to use it. And there's a lot of misconceptions that we need to overcome. Thank you. Yeah, absolutely. Thanks a lot.